Each year, millions of Europeans hear the words they never expected. You have cancer. But behind those words, there are stories of resilience, hope, and innovation. With the Cancer Mission, the European Union brings together patients, medical professionals, policymakers, and researchers united around one goal: improving more than 3 million lives by 2030. Today, many people are embracing moments they once feared they'd miss. Thanks to you, we have breakthroughs that were once thought impossible. Thanks to you, we are making the difference.
Good morning, everyone. Thank you. Welcome to Copenhagen. Welcome to this EU Cancer Mission Conference. I am Mette Valsted Vestergaard. I'm a journalist, and I'll be your moderator today. Jeg vil også sige godmorgen og velkommen til jer, der taler sundhedssprog her. Det tror jeg, en del af jer gør, og vi vil komme til at veksle en lille smule i løbet af dagen. As I just said, we will go a little bit back and forward from Danish to English today, mostly English, and translation, as you have hopefully found out, is available. And let me start out by a small announcement. This is not just another cancer conference. Rather, you should see this as a showcase of the EU Cancer Mission in action. As you may know, the Cancer Mission is one of the 5 EU missions launched in 2021 under the Horizon Europe program, representing what we would like to see as a rather bold new approach to addressing some of the most significant challenges in Europe as of right now. Speaking for the Cancer Mission, it has set out a quite audacious goal for itself by 2030, which is to improve the lives of 3 million Europeans living with cancer. A target that, of course, can only be reached in a combination of prevention, better and earlier detection, more effective diagnosis and treatment, and improving quality of life for those who live with and also beyond cancer. So the idea today is to bring together a broad range of cancer stakeholders, if you can call it that, including, of course, researchers, clinicians, patients, patient advocates, policymakers, you name it. Because it's, to us, imperative that we try to work together across sectors and across interests. Because if we want to achieve our goal of creating concrete solutions, we have to bring concrete people together to talk to each other. The conference today is going to be a quite interactive one, and to help us with that, we'll be using Slido. I trust you're all familiar with Slido. We'll use that both for asking you questions and also for co-creating a few things as we go along. I will explain that during the day. Just mentioning first, we have the QR code here. So you just point your phone camera towards it and it should send you right in. And if not, just go to slido.com and it should work if you tap in these codes. All the Wi-Fi and everything else, the hashtags and everything else is on there as well. And we'll be putting this on many times during the day, so you have it. Slido is also available for the ones of you joining us online, and also a warm welcome and good morning to you sitting back there in your offices or in your homes today. The translation from English into Danish or the other way around is also available for you. There is a channel for that, and that I have been told, I have not seen it myself, but I have been told it should be quite self-explanatory. From this stage, you'll be hearing from researchers, clinicians, leading mission-funded projects or other excellent EU or national initiatives. You'll meet policymakers shaping the direction of the mission, and of course, patients whose lives are touched by this work. So I think we're ready to get started, aren't we? Our first keynote speaker this morning embodies what I would call the core of the strategic vision behind the EU Cancer Mission. Ms. Joanna Drake serves as Deputy Director General at the European Commission's Directorate General for Research and Innovation, and she's been instrumental in ensuring that the Cancer Mission delivers. Under her leadership, the mission has transformed from an ambitious concept into concrete actions, delivering real-world impact. In her speech, Ms. Drake will share the Commission's vision for revolutionizing cancer care across Europe. So please join me now in warmly welcoming Deputy Director General Joanna Drake.
Thank you very much. And I'm really glad that in Copenhagen, there are a lot of tall people, you really think about the short ones. Very inclusive society. So, ladies and gentlemen, those present in the room and those who are online, and dear Mette as well, thank you so much for the warm words of welcome. Esteemed colleagues, it is indeed a real privilege to open this important conference dedicated to one of the European Union's most ambitious health research initiatives, the Cancer Mission. I have to say that you have made a lot of comments about, the leadership, the ambition, and I have to say immediately, that it has really grown close to my heart thanks to the dedication, the competence of my colleagues, represented here by Annika, and of course the board members as well. One of them is there, sitting there very, very humbly. And I have to say that it grows on us day by day, because we see how much Europe can make a difference. Because cancer is there, cancer groups have been there, have been organized, have been, sometimes well-funded. Research has been organized and well-funded as well over time. It touches us, but I think Europe can make a big difference because we want to work together, join up actions, be more strategic. And this is, I think, what the Cancer Mission aims to do, and very inclusive as well, including the patients in decision-making and important strategic decisions that are taken. So I proudly serve as the mission manager of this Cancer Mission, launched in 2021. It is a very bold, it is a very ambitious goal. We put a number to it, 3 million. Not that we don't care about the rest, but we had to test the methodology. We had to test how much this collaborative methodology actually works. And we wanted to really track the progress. And 5 years down the line, this is what we are doing. We wanted to emphasize that we could do better prevention, we could do earlier diagnosis. These are things that we hear about every day. If not in the news media, I'm sure that in the circles, our national circles, our regional circles, our hospital circles, our family circles, sadly as well. We want more effective treatment, we want more improved quality of life for those affected by cancer, but also those that are around those who are affected by cancer directly, that is their families, their friends. And we want to give them back a life, even if they survive. And this is why we have also made quite a lot of emphasis on the young cancer survivors, because it is not a given that when they survive, they have a life, the real life, family life, work life, normal life. So we have today gathered to showcase how this mission is delivering real-world results, how innovation is transforming diagnosis, and also the decisions on treatment, and how this is directly benefiting patients across Europe. We shall be hearing throughout the day how breakthroughs in areas such as liquid biopsy, immunotherapy, metabolic targeting, and integrated diagnostics are helping to boost survival rates and to enhance the quality of life. And this conference itself is, in itself, the result of extraordinary collaboration. It brings together healthcare professionals and organizations, cancer patients, survivors, patient associations, researchers, mission board members, project coordinators and partners, and many, many others. And I really want to express my deepest thanks at this juncture already to all of you for your outstanding cooperation, continuous support and active engagement, and for making it so palpable, so visible. This joint effort reflects the very essence of the EU Cancer Mission, working together to turn scientific knowledge into tangible health benefits for all Europeans. Together with the Europe's Beating Cancer Plan, which is the plan which was thought up and launched just before the Cancer Mission by another department of the Commission, but with whom we have teamed up from day one to actually give a palpable and visible meaning to collaboration. The Cancer Mission actually, together with the plan, form the backbone of what the EU wants to do for cancer. It actually stands for a comprehensive approach for tackling cancer. The objective being very clear: better prevention, smarter detection, more effective treatment, and ultimately longer and better lives. Both initiatives are built on shared goals, complementary flagship actions, and a joint governance structure. These sound like the most obvious if you want to do something that has an impact, but I can tell you, and I'm sure you have your own experiences, it is not an obvious. You really have to work at it every day. And the implementation is supported by synergized actions and strategic investments across funding programs, of course. You can't just have a joined-up governance. You have to have also joined-up planning and joined-up funding for the projects that you plan ahead, and with blended instruments, if possible. The governance model brings together health and research ministries at EU level, fostering an integrated, continued dialogue around cancer policy. It ensures that scientific discoveries directly inform political decisions, and that innovation translates into better healthcare delivery. Again, not an obvious that two ministries would be talking to each other all the time to collaborate and to join up actions and strategies, especially on one of the major killers of our humanity, that is cancer. And less so does it happen on a daily basis. But I have to say that even within the European Commission, the advisors, science advisors being part of policymaking has had a new lease of life, I would say, to actually really trigger also the building of an ecosystem within the member states for this to happen more visibly. Because I think scientific evidence is even more important for and seen to be forming part at an early stage in a timely manner for political decisions, for better political decisions, including naturally on cancer. Together, the EU Cancer Mission and Europe's Beating Cancer Plan have already committed close to 3 billion euros between 2024 to a complementary portfolio of research and cancer care projects. And this, of course, has increased the momentum. It has mobilized the cancer community at both the EU and the national levels. And therefore, the visibility part of this, I think, is so important to continue the momentum and to go faster and achieve better results. Nowhere is innovation more transformative than in personalized medicine. Thanks to the rapid advances in genomics and technology, we can now tailor treatments to the unique genetic makeup of a patient's cancer. This means more effective therapies, perhaps less invasive, fewer side effects, and ultimately better outcomes. At the same time, innovations such as liquid biopsy are revolutionizing early detection. These methods allow us to identify cancers earlier than ever before, often before the symptoms even appear, when treatment is most effective and survival rates are the highest. Through EU Cancer Mission, we are supporting around 20 clinical trials focused on the development of innovative diagnostics and treatments, with a particular emphasis on refractory and rare cancers, including pediatric cancers. Clinical trials are the bridge between discovery and delivery. They not only bring new hope to patients by providing early access to cutting-edge therapies, but also strengthen Europe's innovation ecosystem, boosting competitiveness and economic growth. The European Parliament and the Member States have already begun discussions on what we call internally the next multi-annual financial framework, complex set of words to mean the budget, the next budget, the 7-year cycle of the budget starting from 2028. And of course, this includes the next framework program, which is, again, in internal jargon, we call FP10, because we arrived to number 10 of this framework program. And when we say framework program, we're talking about the successor of Horizon Europe. And this will shape the priorities and funding for research and innovation from now to 2030. Why do I mention 2030? Because cancer, the missions, all the 5 missions, cancer being one of them, have been launched on a decadal challenge, if you like, that they will achieve their objectives within a decade. Within this context, there is great potential to scale up the synergies created by the EU mission so far. For cancer research, this will mean, for example, strengthening the clinical oncology ecosystem, fully in line with the ambitions of the new Life Sciences Strategy, the soon upcoming Biotech Act, and the European Competitiveness Fund under the next multi-annual financial framework, the budget. These initiatives will help ensure that Europe remains a global leader in cancer research and care, turning scientific excellence into tangible health benefits for all. However, innovation must not create new divides. The fight against cancer must be firmly entrenched into equity, and I would say the continuous fight for getting the balance right for equity in Europe. It is not enough to develop breakthrough therapies. We must ensure they remain and become accessible to everyone, regardless of geography, background, or income. Every European citizen should have access to the same standard of prevention, diagnosis, and treatment, no matter where they live. No one should be left behind. As we embrace these innovations, we must also remember that cancer care is not only about treating the disease, it is about improving the quality of life for patients, survivors, and their families. Personalized medicine is helping us move toward a holistic approach to care, one that considers not just survival rates, but also the emotional, the social, the economic challenges that accompany a cancer diagnosis, indeed a very holistic approach. And I think this shows that Europe is interested in making a deeper understanding of what cancer and its effects are on humanity. Healing is not only a biological aim, it is also reaching the human aims too. Horizon Europe, as well as Horizon 2020 and FP7, Framework Programme 7, support hundreds of projects addressing personalized medicine and focusing on scientific innovation in the oncology area. Horizon Europe co-funds, for example, EP per Med, European Partnership in Personalized Medicine, which runs from 2023 to 2033. And 10 years ago, the International Consortium for Personalized Medicine, IC per Med, was established. It aims to coordinate personalized medicine research efforts and demonstrate its benefits to healthcare systems. This is so important. But our success depends on all of us, the governments, the researchers, the clinicians, the patients, the communities, the community of practice, working together to push the boundaries of what is possible. The path forward is clear. Innovation must lead the way, and collaboration must drive it. The EU Cancer Mission is showing that when we unite behind a shared vision, we can accelerate progress, we can deliver better outcomes, and we can bring hope to millions. So, ladies and gentlemen, whether present in the room or online, I look forward to your very active contributions today, participation in discussions, to hearing your insights, your ideas, to seeing how the work showcased here will help shape the future of cancer in Europe. Thank you so much for your attention, and wishing you a very successful and very inspiring conference. Thank you.
Thank you. Thank you very much, Ms. Drake. We'll now hear from another very important European voice on cancer policy, Mrs. Stine Bosse. She's a member of the European Parliament, where she's the vice chair of the Committee on Public Health. And she's also known to be a passionate advocate for cancer research and for patient care. She has recorded a special message for us because she unfortunately couldn't be here today, but she does have a few words for us.
First of all, I'm very, very sorry that I could not be with you today. I would have loved to be with you in person. But let me just address some of the most important issues that we are seeing right now. We're facing 3 million people annually diagnosed with cancer in Europe, and the numbers are rising. This, of course, we need to face, we need to understand why, and we need to work together to find better solutions. That goes for personalized medicines, that goes for treatments, that goes for how do we actually care for people where treatment is impossible, but where you can still live quite a long life, but live with the cancer. All these issues, we can only be very clever together, and that's why I am a very big champion of the fact that we should work much closer, much more together in Europe to solve these issues, and for all patients in Europe.
Well, thank you to Mrs. Bosse. So while Ms. Drake and Mrs. Bosse reminds us about the strategic importance of cancer research at the EU policy level, it's also crucial to remember that all the policy and all the research and all the innovation rests on one solid foundation, one raison d'etre, if you will, which is to improve the lives of people with cancer and their families. The EU Cancer Mission is strongly committed to put patients at the center of everything. That means every research project, every innovation, every policy decision must ultimately answer the one question of importance, which is how does this improve the lives of cancer patients and their families? And you're going to meet a patient now, a cancer patient. Andrea Elisabeth Rudolph is her name. She's a quite famous Danish media personality. She's a wildly successful entrepreneur, and she's also a cancer survivor. She's an outspoken advocate for cancer awareness and patient-centered care, and she has generously chosen to use her platform to give voice to patients' needs, patients' experiences. So I want you to welcome warmly now, Andrea Elisabeth Rudolph. Thank you. Have a seat.
Thank you.
We have decided to do this interview in Danish, so if you need translation for this, please get the equipment over here. You may want to pass that around. Andrea,
Thank you for inviting me.
jeg har jo hørt dig tale engelsk, og det kan du sagtens finde ud af. Men det her, det er noget andet, fordi det her er...
Nu går alle.
Nu går alle.
Wow.
We'll wait for them to
I
get.
never tried that. People leaving when I'm going to speak. Wow, it's the first time. It's the first time for everything.
That's because they want to hear you, and they want to understand you. So we'll let them. Well, we can touch on that first because
So
they
they're
can
leaving
hear
to hear?
you're fine in English. So, but speaking about your experience as a cancer patient is just different.
It is very different because
Yeah.
it's a very, first of all, a very emotional thing. Also, it's, I think my technical language, my technical words in this area, on this topic, I don't have the technical
Terms and
terms
place.
in English for that yet.
We'll stay clear of the technical terms, I
Okay,
think,
good, great.
but yet we'll still do it in Danish.
Okay, wonderful.
I think everybody has their translation equipment ready.
And thank you again for inviting me.
But these are all people that are used to the whole EU circus, and they're used to having translation, so don't worry.
Good. Thank
Okay, Andrea. Lad os lige starte med at spole tiden næsten præcis 5 år tilbage. Og du er jo du er en del af en familie. Der er 5 børn. Du har en mand. Du har startet en forretning, som er sindssygt succesfuld. Det kan jeg sige til dem, der ikke kender Rudolf Kjær. Du gik i gang med at lave hudpleje, skincare-produkter på et tidspunkt. Meget specifikt uden kemi.
Uden skadelig kemi.
Uden skadelig
der er
kemi. Ja, det er
uden,
klart.
Altså,
Alt er jo
der er
kemi,
masser af kemi, men der er
uden
stor
skadelig
forskel
kemi.
på, om det er den, der
Efter du
skader
fik
dig.
den oplevelse at få målt, hvad du selv havde af skadelig kemi i kroppen, som måske nok stammede fra den slags produkter, og blev forskrækket over det, og laver det her. Du har også en fortid. Vi har arbejdet i samme selskab en gang, nemlig Danish Broadcast, Danmarks Radio. Alt går godt. Og hvad sker der så?
Ja, så sker der det, at jeg en aften, hvor jeg lige har været i bad, sidder på min seng, har lige tørret mig, og så mærker jeg, at jeg har noget under min venstre arm. Og det er sådan en knude på størrelse med en lidt stor oliven. Og det mærkes forkert lige med det samme. Ja. Og med det samme tænker jeg, at der er noget galt.
Ja.
Så dagen efter, og mandagen, ringer jeg til min læge og får en tid. Og kommer dagen efter og bliver undersøgt, og han er meget stille.
Ja.
Han plejer ikke at være så stille.
Nej.
Og sidenhen har han jo fortalt mig, at han aldrig har mærket noget, der var så fremskredent. Så det var brystkræft, der havde spredt sig, og en uge efter er jeg på Rigshospitalet, får mammografi, får ultralydsscanning, og allerede der får jeg at vide, at det er kræft. Allerede inden der er lavet en biopsi, fordi det er så tydeligt. Ja. Men den biopsi bliver så også lavet, og præcis en uge efter er jeg i et kemoforløb.
Wow.
Ja.
Det gik stærkt.
Det gik stærkt, og det skulle gå stærkt. Ja. Og min læge sagde, hvis du ikke hører fra Rigshospitalet inden for en uge, så skal du ringe til mig. Men jeg hørte fra dem samme dag. Ja. Så det gik meget stærkt. Ja. Men, og det er jo sådan alt sammen det praktiske. Og det, der skete med mig, var, at jeg blev ramt af en ekstrem skam.
Skam?
Ja, hvorfor? En skam over at være blevet syg. En skam over, at jeg havde gjort noget forkert.
Du blev rørt nu, kan jeg se. Det kan jeg godt forstå. Det var, jeg tror for de fleste, der kender dig, og det gør alle danskere jo, der var det også sådan, jeg tror folk sagde, jamen hun er jo den sundeste i verden, hvordan kan hun blive syg? Hvordan?
Ja, jeg har i hvert fald altid følt mig ekstremt stærk og sund, og er vokset op på landet og dyrket meget sport, og haft nogle forældre, som har gået meget op i sund mad, og så jeg følte mig stærk og kraftfuld. Men så var jeg lige pludselig syg. Og jeg tænkte, okay, der er noget, jeg har gjort forkert der. Jeg har fejlet. Vred på min krop. Skuffet over min krop, som jeg forventer noget af hver dag. Det fik jeg heldigvis hurtigt vendt. Fordi jeg havde en veninde, der sagde, Andrea, du må ikke skælde ud. Din krop har jo faktisk allerede prøvet at slå de her celler ihjel. Så du skal hjælpe den. Nu skal vi hjælpe din krop. Så jeg fik det hurtigt vendt. Men min store bekymring gik ikke på min forretning. Min store bekymring gik selvfølgelig på, at jeg har 5 børn. Og jeg var selv 44. Mit yngste barn var 3.
Det er okay.
3, 5, 8 13 og 14.
Når man bliver syg, når man er børn, så er man jo ikke bange for at dø selv. Man er bange for, at ens børn skal miste deres mor.
Ja. Bange for at skulle forlade dem. At skulle svigte dem. Ja. Så jeg havde et job, og det var at blive rask. Og jeg synes, jeg har været igennem et på mange måder fantastisk forløb på Rigshospitalet. Jeg har følt mig tryg. Jeg har følt mig i gode hænder. Jeg har følt mig lyttet til og set, men man kommer selvfølgelig også ind i en maskine, som kører. Og hvor ingen vil love en noget, selvfølgelig.
Og hvordan var det? Altså, hvad var det for en fornemmelse, det gav? Fordi det er klart, læger har jo en stærk og vigtig faglighed, men hvordan var den oplevelse, hvis du tager den sådan fra rent patientperspektiv og uden at...
Altså, jeg kan huske, at jeg fik sådan en mappe udleveret, hvor jeg så kunne... så begyndte de at fortælle mig om, at du kommer til at få vildt meget kvalme, og du kommer til at... Og sådan, ikke? Så de fortalte bare sådan alle de dårlige ting. Jeg husker, jeg fik sådan en mappe. Jeg læste den aldrig. Altså... gider jeg simpelthen ikke.
De elsker brochurer.
Ja, det var nemlig sådan en folder og brochurer og en mappe, og jeg tænkte, det skal jeg ikke. Altså, og jeg synes, hun fortalte mig også, at jamen, du vil også opleve, at når du kommer her igen, så vil du kunne smage kemoen allerede. Altså, så jeg fik jo ligesom at vide, jeg tror, man kunne også have angrebet det på en anden måde. På en eller anden måde kunne man have, det ved jeg ikke, jeg har selv en positiv hat på, og vil gerne selv finde min vej, også. Men jeg havde brug for alt det, jeg havde brug, altså fra Rigshospitalet. Jeg fik kemo, jeg er blevet opereret, fået fjernet mit bryst, jeg har fået fjernet mine lymfer, fordi det havde spredt sig, og jeg havde ikke en hormonfølsom kræft. Men jeg havde en voldsom, en hurtigt aggressiv kræftform, som kemoen heldigvis virkede rigtig godt på. Så har jeg fået stråling senere, og jeg har også fået antistoffer. Så jeg har gået igennem et rigtig godt forløb, men det, som frustrerede mig undervejs, det var, at jeg ikke kunne få hjælp til noget andet.
Og noget andet, altså alt det uden om selve det, der handlede om den knude, er det det, du mener?
Ja, altså om min kost, mine vitaminer, hvordan skulle jeg leve, hvad var det bedste, jeg kunne gøre for mig selv, sådan et helhedsbillede. Og der synes jeg, det var sådan meget, altså jeg fik et kostråd, og det var, at jeg ikke skulle spise brændt brød, eller brændt mad, altså sort mad, altså noget, der havde sådan ligget for længe på en grill eller en brødrester.
Tror du det er fordi, at læger er bange for at sige, det er madens skyld, du er blevet syg, eller altså, hvor kommer det fra?
Altså jeg vil sige, at jeg har jo selv startet min egen forretning, netop for at undgå rigtig meget af den kemi, som der er en risiko forbundet med, gør os syge med kræft, gør os barnløse, og gør, at vi føder børn med misdannelser, som der også kommer flere og flere af. Så det har været et aktivt valg, og jeg har ændret. Jeg vidste jo, fra dengang, der sagde du har en risiko for kræft, du har et risiko for at få børn, som har en misdannelse. Nu har jeg haft kræft, og jeg har født et af mine børn med en misdannelse. Så i 20 år, lige om lidt, har jeg faktisk arbejdet på at prøve at ændre den her verden, og jeg ser et landbrug, der får lov til bare, altså være sød at gå ind og banke på hos jeres EU-venner omkring det her landbrug, der bare ødelægger vores drikkevand, alle de her evighedskemikalier, der spreder sig, det er jeg en kæmpe advokat for, vi bliver skidesyge, og der er flere og flere sygdomme, som vi også hører Miss Drake forklare, at det her cancer, det er increasing, og det skyldes mange ting, hvad vi omgiver os med, vores livsstil. Og jeg havde brug for at få hjælp til, hvad kan jeg mere gøre selv? Ja. Altså en ting var alt det, som et hospital kunne hjælpe mig med, men hvad kunne jeg ellers gøre?
Altså for at styrke kroppen til at kunne modstå behandlingen, for eksempel, hvis vi så bare bliver inden for den del af det, som vel også er væsentligt.
Ja, altså jeg tror på, at jeg er kommet igennem det her, fordi at jeg er vanvittig ressourcestærk. Ja. Og jeg bruger min stemme i Danmark, og jeg vil fortsat bruge den, og jeg vil virkelig gerne bruge den i Europa også, til de, som ikke har den samme stemme som jeg. Ja. Jeg er kommet igennem det her, fordi at jeg har fået en god behandling, men jeg er også kommet igennem det, fordi jeg er vanvittig ressourcestærk. Jeg har en stærk økonomi, jeg har et kæmpe netværk. Jeg er selv journalist, jeg kan selv finde ud af at opsøge ting, jeg har selv betalt for mange alternative behandlinger ved siden af. Og jeg er en kæmpe advokat for cannabis, medicinsk cannabis, som jeg modtog, og det var ret...
Og hvad var det, du brugte det til?
Jamen, det brugte jeg til, det var ikke sådan noget... Altså, faktisk må alle læger i Danmark udskrive medicinsk cannabis, men ingen gør det. Alle er bange for det. Til gengæld udskriver de, hvad hedder det der, slankemiddel nu? Altså, det udskriver de jo sådan her. Altså, jeg har jo venner, der får det slankemiddel udskrevet af ikke engang deres eget læge. Det er det letteste at få fat i. Kender vi langtidseffekten af det? Altså, cannabis er ikke nyt.
Men hvad brugte du cannabis til?
Jeg brugte cannabis til, og jeg fik kun fat i det. Jeg slap for at gå på det sorte marked. Jeg fik fat i Danmarks førende cannabislæge, som har været overlæge på Glostrup Hospital i Danmark og Rigshospitalet i mange år, i 20 år. Og hun, fordi jeg havde en veninde, der var veninde med hende, fik jeg lov til at springe køen over.
Og det kunne hjælpe dig med din appetit?
Det, der sker med cannabis, det gjorde for mig, det var, jeg var sulten. Så selvom jeg fik behandlinger, der gjorde mig så syg, jeg kastede op og kastede op og kastede op. Jeg var så dårlig, så spiste jeg. Jeg fik mad. Jeg tabte mig ikke særlig meget, for jeg var sulten, og så jeg blev ved med at spise. Jeg sov fantastisk. Jeg har aldrig sovet så godt i mit liv, som... og det har man brug for du har brug for at samle kræfter.
Hvorfor ville det have været vigtigt for dig, at dine kræftlæger også var en del af hele den der, det vi kan kalde lidt uden om selve det at fjerne en tumor?
Jeg tror, det ville have gjort mig mere tryg, og jeg tror, det er bare, at vi er... Jeg var jo bange for, at noget af det, jeg kunne finde på at gøre selv ved siden af, skulle ødelægge noget af det, de havde gang i. Men så jeg var hele tiden åben og fortalte dem, hvad jeg gjorde, hvad jeg tog, hvad jeg ikke tog. Fordi at jeg vil gerne have deres, at de var sådan, okay, det er fint, du gør det, men vi kan ikke støtte det, vi tror ikke på det, og det var. Men det gjorde noget godt for mig. Jeg var aldrig skæv af det. Altså jeg blev aldrig påvirket, som om jeg havde taget et rusmiddel. Men det gjorde for mig var, at det gav mig en ro, og jeg tror på, at jeg har et positivt mindset i forvejen, men det blev ikke dårligere. Jeg havde en tro på, og tankens kraft må vi ikke undervurdere. Og det er derfor, vi skal tale om både i cancerbehandling skal vi tale om tankens kraft, om vores mindset, om vores indstilling. Vi skal tale om det at kunne forestille sig ting. Altså simpelthen det at kunne, jeg mangler det ord, når man forestiller sig ting. Hvad er det? Det er man... Jeg gør det tit, hvis jeg skal præstere i noget. Ja, så laver jeg visualiserer det. Ja. Så visualiserer. Så når jeg fik min kemo, så bød jeg den velkommen i min krop. Jeg havde ikke modstand til den. Jeg bød den velkommen. Og den skulle ind, og den skulle komme ind, og jeg så, hvordan den slog kræftcellerne ihjel.
Så mere lægelig deltagelse i den ting. Når nu du tager rundt og fortæller det her, for det gør du jo, at du bruger tid på det, og du har altså stadigvæk en stor butik at drive, så du bruger noget tid af dit liv på at tage rundt og bringe de her budskaber. Hvad er det, du håber at opnå med det?
Jeg håber at opnå en større hjælp til både selvfølgelig et forløbet igennem kræft, men når man så bliver erklæret kræftfri, fordi rask bliver du ikke erklæret, men når du bliver erklæret kræftfri, så står du alene. Ja. Og det er faktisk først der, hele arbejdet starter. Ja. Fordi mens du har kræft, så er du i et fighting mode. Du er i kamp. Og bagefter, så ånder du ud, og så kommer der en tsunami af frygt, af rædsel. Du har været igennem en krig, en naturkatastrofe, følte jeg, min krop havde været igennem. Det har taget mig mange år, og jeg har været heldig, at jeg har haft en forretning, der har gjort, at jeg ikke skulle tilbage på arbejde. Jeg vil aldrig have gået tilbage på mit arbejde efter et år. Jeg var der for første gang 1,5 år efter, at jeg var blevet syg, og der måtte jeg starte med at være der en halv time, og så stille og roligt en time. Jeg er stadigvæk ikke på fuld tid. Jeg nyder naturen. Jeg skal ud i naturen. Jeg skal ud og ride på en hest. Jeg skal lægge mig i græsset. Jeg skal være omkring træerne. Jeg skal være med min familie. Dem, jeg elsker. Men jeg ser kvinder, nu også mænd selvfølgelig, men primært kvinder med brystkræft. Jeg kan jo kende dem. Jeg kan se dem. For nylig tjekkede jeg ind på sådan et badehotel med mine børn. Og der står en dame ved computeren, som er korthåret og krøller og skal hjælpe os. Og jeg kan se, hun sveder, hun er forvirret, hendes øjne flakker rundt på skærmen.
Du kan se,
og jeg kan se, at hun var en søster. Så hun undskylder. Undskyld, jeg er lidt forvirret, jeg er lidt langsom. Og så siger jeg til hende, du skal ikke undskylde. Jeg ved, Jeg kender alt til at være forvirret. Jeg har haft brystkræft engang. Det har taget mig mange år. Min hjerne var fuldstændig brændt af. Jeg kan stadigvæk ikke huske ting. Men alle folk siger til mig, du ser godt ud, du er frisk, nu er du tilbage, det er dejligt. Men alt indeni er i stykker. Og en hel familie bliver ramt, det er ikke bare mig. Jeg har børn, som har måttet droppe ud af skolen, som har kæmpet, og jeg er blevet skilt efterfølgende. Man bliver bange i sådan et forløb, for at kærligheden fra ens elskede, at de løber tør for kærlighed, for vi går alle sammen igennem det samme.
Andrea, det er generøst af dig, at du vil gå ud og fortælle om din oplevelse og sende dit budskab. Jeg vil takke dig for at komme her og tale med mig i dag.
Tak selv.
Now, to understand how Cancer Mission works, we will now turn to the team that coordinates the mission's day-to-day operation. Mrs. Annika Novak leads the Cancer Mission Secretariat at the EU Commission, and she works directly with member states, Cancer Mission board members, research consortia, and stakeholders across Europe to ensure the mission delivers on its very ambitious goals. Please welcome her.
Thank you.
Oh, you forgot to welcome her.
Good morning, everybody. It's a great pleasure now to dive more into what a mission approach entails, and it's a bit of a difficult task after such a touching interview, and I think it was really, always the encouragement to continue and knowing why we are doing that. So John has already alluded to some of the elements. What does it mean, the integrated approach of a mission? So I want to just, capture this. But before I dive into that a bit more in detail, I would like to say, what's the mission in brief, just to remind everybody. So we have started in 21, so 400 years something. And the mission, the donation as such, is a large-scale initiative. So it's the funding, but it's the portfolio of actions we are doing. Time-bound, so we have until 2030, 5 more years to go. And it's really societal challenges that we are tackling. So it's about climate change missions we have, but we have the cancer, soil health. So always is also important in the area of cancer to have healthy soils. So by bringing together, the researcher, policymakers, citizens, stakeholders, you name it, it's about pooling the resources to foster the collaboration. That has already been mentioned, and it's among the healthcare professionals, the researchers, the citizens, and you name it. Well, the mission stretches over 4 objectives, from understanding the quality of life, and we just heard quality of life is so important to live also after you had a cancer episode. And that's why we put also lots of focus of our investments and resources there. That's coupled with transversal priorities, personalized medicine being one of them, but also citizen engagement and the equity. I think that's really also guiding how we design the projects and our actions. Well, let's move on. Time is running. So I will dive into what means the engagement and also what is the building synergies, what we have achieved so far. So can I have the next slide, please? So Joanna has already mentioned we had such an opportunity in 2021 with 2 dedicated EU initiatives. The Cancer Mission, funded under the Horizon Europe as more the research arm, but it goes much beyond the research on the one side, and the Europe's Beating Cancer Plan, so the policy instrument at EU level as a combined effort at EU level. And with that, we designed it also in a way to have aligned objectives, complementary flagship initiatives, such as the Uncanny EU data platform, a huge undertaking. And building a joint government was the only solution to ensure that we also have an integrated implementation of these 2 dedicated cancer initiatives, as well as many other related EU actions. So what does it mean? It's a dialogue we foster, but it's in more dry words, it's an expert group where we put together delegates from health and research ministries. So it's this continued dialogue and exchange that we have almost every second month at EU level. They advise us to design policy actions or what is needed in terms of research and innovation, but they're also there to absorb what is going on at EU level on health and research, but also on digital policies, on environmental research. It's also to bringing then the other Commission departments together and feed that group to make sure that the member states are aware what's going on at EU level and bring that then to the national level. And that brings me to the national level, because we felt this integrated approach at EU level is great, also with respect to the stakeholders, but we need to bring things down to the national and regional level. And I know in Danish the regions have a very strong role in healthcare, and that's also the case in many other member states. That's where the decisions are made on reimbursement issues, on screening programs. So that's why we are fostering a network, building a network, what we call a national cancer mission hubs. So entities at the national level that replicate that integrated approach, that bring together the national stakeholders of a broad range, that organize policy dialogues to adapt what's going on at EU level and actions on policy measures, to adapt it to the national and regional needs, and to make sure it's being implemented. So that's supported by a project launched under the mission, the ECOS. So again, this integrated approach allows us really then to build the synergies that are needed. The investment under the cancer plan is important. So far, we have already almost 500 million invested into 62 projects, some of them being presented today, across always the 4 objectives. And let me stress again, quality of life being one of very important investment at EU level. The plan, almost the same amount, so from 21 to 24, the next work programs are in the pipeline. Our next program should be adopted 26, 27, shortly before Christmas. So putting that together, it's the basis for also design the actions that stand behind the projects and the activities for a greater impact, but really to also to complement issues that we come on from the cancer side, but we look what is on the priority list of policy actions, how we can support the design, but also then when it comes to implementation, in combination with the dialogue of the member states, with the stakeholders, and you name it. Next slide is, next 2 slides will illustrate a bit. I won't go through into the details what has happened, but it's just to show you the number of actions and always where we try to combine the actions so that we don't work or remain working in silos at the Commission level, but really to push also the member states to do the same. Well, in the area of optimizing the diagnostic and treatment, the theme of today's conference, we will hear about the projects, the clinical trials that we have. There, within the projects, we foster the collaboration also among the projects, the researchers, through cluster building in a given area of an objective. So to foster the collaboration, they should do things together, but also we organize policy webinars to expose, to align it, to reach out to more stakeholders, and to give also early insights, what's going on in the projects. Outreach campaign, obviously very important. Conferences we are doing, but also citizens engagement, dedicated initiatives such as bus roadshow that we had last year. Well, research capacity is also important. Some investments got there. On the cancer plan, you see just a couple of actions. It's not exhaustive, so it's also digital elements where we bring in. So combining really all the EU instruments and programs, this is what it's all about, and giving the visibility to that. So final slide should give you a bit more of insight. Again, also listing what has been done under the mission, but also looking what is else the Horizon Europe program offering in terms of boosting personalized medicine. John has already alluded to the partnership on personalized medicine that really aims to improve the outcomes with personalized medicine approaches, but we also have the Innovative Health Initiative that has many projects important to accelerate or to have PM approaches in that. There are other dedicated projects I just wanted to highlight. I don't go soon, but it's also looking into personalized prevention, pre-commercial procurement, again, with the aim to have a comprehensive package of actions, not just single projects, but aligning them and complementing them with actions to make sure that these are implemented at the national level. And I think with that, I can finish my run through what is the mission doing in terms of collaboration and synergizing actions, and hand back to our moderator.
Thank you. So, having now heard the strategic vision from the Commission and the EU Parliament, and the operational framework from Ms. Novak here, and also a very touching patient's voice, we now dive into the science. And our first panel today is going to focus on diagnostics. One of the cancer mission's primary objectives is to enhance cancer screening and precision diagnostics, enabling earlier and not least more accurate detection. Detecting cancer early, as you probably know, and nonetheless, detecting it precisely saves more lives with better outcomes. So this session highlights how the Cancer Mission and other European-led and national initiatives are transforming both screening approaches and diagnostic technologies to identify cancer sooner and with greater certainty. So before I invite our panelists up here, I'm going to invite you to co-create with me a word cloud. I trust you're familiar with a word cloud, so you know that in a word cloud, it works best if everybody writes just one word, because if you start writing sentences, we kind of don't get that function where the word that most people write will grow bigger. So try to see if you can find that keyword that comes to head. And you go into Slido, and we have the QR code here. And if it doesn't work, you can go to slido.com and you type that code right here, Mission Cancer. But I think the QR code should send you right into the Slido. And in a couple of minutes, or probably a little less, the words will start appearing. Oh, already they are. In one word, what do you think is the biggest challenge in early detection and precision diagnostics? And to specify, this is meant for across Europe. So in one word, what do you think is the biggest challenge in early detection and precision diagnostics? Money. Now, that's a big one. Resources, yeah, funding. Access. Definitely overdiagnosis. That's interesting. Targeting. The mental shock. Interesting. Technologies. Ethic. Data. Equity. Fragmentation. Bureaucracy. Also interesting. Biomarkers, lead time, resources, bureaucracy. Yeah. Access, funding. They're equally big, aren't they? Common knowledge. Doctors. I hope doctors are not the biggest challenge in early detection. That's a problem. Maybe it's the scarcity of specialized doctors that the person means. Misallocation of funds. The whole funding thing is important here. Okay. So while the last ones, I can see some of the participants are still typing, and I'll let you type. And in the meantime, I'll invite my panelists up here, Dr. Maria Carla Parini and Professor Klaus Pantel. Welcome. Please have a seat. Why don't you take a seat here, Dr. Parini? Yes. So, Dr. Parini from the Institut Curie in France, the Arturo project, where you're the coordinator,
Right.
and have the focus of tumor microbiota and resistant mechanisms using tumor-on-chip technology.
Right.
Just briefly, what is tumor-on-chip technology, just for everybody who is not familiar
sure.
with all these terms?
Tumor-on-chip means basically using a nanotechnology, so using a microfluidic device to co-culture cells of the tumor microenvironment. So this is really a very innovative way of reconstituting ex vivo, so outside the body, the complexity of the tumors.
Wow. And Professor Klaus Pantel, Professor Pantel, from University Medical Center Hamburg-Eppendorf, Pancake Project Coordinator, and the focus here, your focus being liquid biopsy for pancreatic cancer and early detection. liquid biopsy. Why is this significant in terms of solid, liquid?
Yeah, I think that in general the diagnosis in cancer is made by a needle biopsy. So you put a needle into a suspicious lesion that is somewhere in your body. And about 15 years ago we have created this term liquid biopsy because we can take now a blood sample, which is much more easier than putting a needle somewhere into your body, and get tumor information from that blood analysis. And that's what we have called liquid biopsy 15 years ago. And this term has been now adapted really worldwide, I think in a very nice fashion, as a new diagnostic, I would say, way.
So, looking at the, can we get the word cloud back for a second so we can just, so let's have a look at it now. You have it right here, yeah, sorry. I don't have to be an acrobat.
You're very flexible, that's good, but.
Access, funding, common knowledge, technology. So if you just, what word would you have written?
Well, I would have chosen the biomarkers.
Biomarkers.
Yeah, biomarkers in the sense markers that allow to make a very precise, personalized diagnosis. Yes.
And Professor Pentel, what word did you write a word?
Well, for me, it's really the clinical implementation gap. I mean, we have thousands, tens of thousands of publications, and we become doctors, professors, and so on. So that's fantastic for us. But I think there are very few of those discoveries that make it into the clinic. And to close that gap, I think, is one of my, I would say, biggest challenges.
All right, well, I'll let you have, now I did already ask you a few questions, but I'll let you have a couple of minutes just to introduce what you're working with, what's your field, and what are you facing, what challenges are you facing right now in the work that you're doing. And for that opening statement, I'll start with you, Dr. Paridi.
Thank you very much. First of all, I really want to thank for the introduction and for the invitation to this conference. I'm really very happy to be here to discuss with all of you the advances of cancer care in Europe. I feel very honored and grateful to the European Cancer Mission that funded our project. The name of the project is Arturo. So yes, we are advancing, I think. I hope, I work for this. And the key driver in this fight against cancer is research in different declination, the fundamental, the translational, and the clinical research. So since more than 20 years, I work at the Curie Institute in Paris. So Marie Curie was a European woman and an extraordinary scientist. She won 2 Nobel Prizes. And she understood a long time ago the necessity to combine research and patient care. So the Curie Institute, where I work, it is composed of a research center. I'm a researcher, but it is also a hospital group where cancer patients are treated. So this integration is really the key of our success. We are advancing, but we still have challenges. And my current challenge, so the topic that we are working by using this tumor-on-chip technology that I briefly explained, the current challenge we are facing is the resistance to treatments. So there are many anti-cancer therapies. Chemotherapies, radiotherapies, immunotherapies, hormonotherapies, target therapies. The number of these treatments is increasing, and this is very good news. But there are still major obstacles, and the major one is that only a fraction of the patients does respond well to these therapies. And we still do not understand why some patient responds and why other patients do not respond. So we need to improve our understanding. We need to make more precise, more personalized diagnosis. And so we need to develop diagnostic tools that predict the response of the patients, to choose the best drug for each patient, to avoid giving useless treatments, to reduce the side effects, so to improve the quality of life of patient, and to save more lives. So the focus of our research, our challenge is the resistance to treatment.
Resistance of treatment. Thank you for that. Professor Pentel, likewise for you.
I'm an MD PhD. I studied medicine in Germany 100 years ago and wanted to become just a normal doctor.
At least 100 years ago.
At least. Going into private practice, that was my goal.
Yeah.
But then I realized when I went to the hospital that so many patients 40 years ago, cancer patients, were dying so quickly, and I thought, well, we have to change that. We have to do something. So I became interested in research more and more. And I think that I also realized that the detection of cancer could become really change because we need to detect earlier. Why? Because, for example, patients in breast cancer, many of them don't know for many years whether the cancer comes back or not.
Yes.
But the cancer is in the body, right? It's not an infectious disease. So I started 35 years ago to find very, very sensitive ways to detect very minute amount of cancer traces in the blood and in the bone marrow. And that work has also led me to attempt actually not early detection of relapse only, and that's what I'm doing in my IHI Guide MRD project, but also early detection of cancer at the very beginning. And that's what we are doing in the PANC8 project, focusing here on early detection of pancreatic cancer, because this is the cancer that's always detected too late, except for a few cases. Yeah. And then I realized, after having published many papers myself, that, wow, it still takes a lot of effort from a good publication to bring something into the clinic for the benefit of the patients. It's not happening by itself. So I established the European Liquid Biopsy Society, which was actually a successor of an EU-funded project. And we went on with this project beyond the funding project. And that's also important. You get money for 3, 4, 5 years from the EU, but then these beautiful networks disappear, right? They're like a bubble, you know? And we decided to go on. We self-organized ourselves, and we are more than 100 institutions now working on the clinical implementation of these liquid biopsy technologies.
And how are you doing?
Well, you cannot say nice things about yourself, right?
Yes, I'm asking you to.
Well, I'm coming from a very conservative parenthood, so you never were doing that, actually. But I think it works very, very well, and I'm so super happy when Joanna was talking about, the things today for the introduction that she mentioned liquid biopsy. And that is always, for me, the biggest gift before Christmas.
Well, we are right before Christmas. Just returning to what you said about integrating these emerging biological insights and utilizing them into diagnostic strategies. Are we well enough equipped to use all these new insights, and what are the gaps? What are the barriers?
Okay, well, it depends on which insights we're speaking. Mm-hmm. So maybe I can focus on the topic of our European project.
Mm-hmm.
So,
yes.
In our project. So we focus on a new player of the tumor microenvironment. It's really a new player. It's the tumor microbiota. So probably all of you are familiar with the gut microbiota. But very, very recently, quite surprising, microorganisms like bacteria have been discovered in many other parts of our body and also in the tumors. When I say recently, it's very recent. So the first publication that proved the existence of bacteria in the tumors is 2020, 5 years ago. So it's very
Quite
new.
novel. Yeah.
It's really very new. So we are currently studying what are the bacteria present in tumors and how they affect the therapy responses. It's totally open question. Well, there are some discoveries published by other groups that found, for example, that some bacteria are capable to metabolize and inactivate some chemotherapies. So, of course, if these bacteria are present in the tumor, then the treatment cannot be effective. But it's very, very new field. We are, in our group, we are focusing on the role of these bacteria in immunotherapy responses. Regarding your question, whether this particular new insight of the tumor microbiota can be easily integrated into the diagnostic strategies, I would say that on one side, there is no major obstacles in the sense that the laboratory of molecular medicine are right now capable to realize standard molecular analysis to detect the presence of the DNA of bacteria within the tumors. So the hospital are theoretically already equipped to make the diagnosis of the presence of bacteria. But there are other obstacles like the fact that the biomass of this bacteria is very low, that there are a lot of contaminant in the air. So there are these kind of obstacles to overcome.
To figure out where does this come from? To
say that figure out to be specific and sensitive and to
Do you have any suspicions?
Suspicious. In the sense where the bacteria comes from to how. This is an open question. The most likely is that the bacteria present in the tumors, they come through the circulation from the gut. But this needs to be proven. We are scientists, so it cannot. This has to be proven, and as the field is new,
of course, a long way ahead.
Yes.
So, when we're talking about what are the gaps? Well, the gap is time in the first place.
The gaps are definitely to get more knowledge and to create more and more interaction between the research and the clinician. I was mentioning before that I'm lucky to work at Curie Institute, where there is this scientific structure that facilitate these exchanges. But this has to be expanded and make available to other centers and other hospitals.
Professor Pentel, let's return to talking a little bit about pancreatic cancer, which is, among other reasons, but it's so deadly because it's detected so late, which is also what you said before. But where are we today? What is the status in terms of early detection, just focusing on Europe now? So where are we exactly with that part of it?
Well, I think we are still in the beginning. I think if you come to your doctor and you want to know whether you have pancreatic cancer or not, there is no specific tests. And it's even worse. There are many human beings that have a small cyst in the pancreas. So you may not even have any problems with the pancreas, It might be just an incidental finding, how we call it, a finding by chance. You go to the doctor, you make a CT scan for some other reasons, and then the radiologist sees there's a small little cyst, we call it, a small little bubble in your pancreas. Then we have some idea where it's located, whether it's more or less dangerous, but more or less dangerous doesn't really help a lot because you don't know, is that developing into pancreatic cancer or not? So you are concerned, right? Then you go back every few months and control this little bubble, and if it gets bigger, you get a bit more concerned. The doctor's also getting more concerned. But you still don't know whether that will develop into cancer or not. And then you go a bit later, and then maybe all of a sudden there is something where everybody is maximally concerned, and they now say, okay, you need surgery. But then it might be too late. So we don't know really when to really intervene, because the surgery is also very complicated. It's not just taking it out, like you take out maybe a mole from the skin or something like that. So you have to have a very good indication that this is really dangerous, this lesion, how we call it. And here I think we have now with the PANC8 a wonderful opportunity, because we have collected blood samples over 10 to 20 years from patients with these little cysts, and we know which of them developed into a cancer, which did not. So we can now analyze the blood with all kinds of technologies. I don't want to go in any details, and find out what are the markers, as we call it, that actually tell you that this is a dangerous pre-neoplastic lesion, a dangerous lesion that develops into cancer, and can this also detect then the cancer at the very, very early stages. And in pancreatic cancer, we really feel that we must detect it as early as possible, maybe even earlier than in other types of tumors, because it's so super aggressive once it's there.
So I'm a bit inspired about, with the network that you have, because, moving from the lab and into the clinician's office and applying it to patients and to diagnostics there is essential, of course. And I get that where you're at right now, this is not where you're at right now in the time frame. But if we think ahead, navigating between works in our lab and into this can actually be standardized and used in the hospitals and the clinics and so on and so forth. Once you've reached the results that you need from neuroscience, what obstacles in your experience do you see there? We've already heard Professor Pintel talk about it a little bit. What obstacles do you see when moving the results you have in your lab and into actual use in the clinics?
Well, to answer to this question, again, I focus on an example of the technology that we are developing. Now is more than 10 years, and so the technology, this tumor on chip, is part of an emerging field, the novel ex vivo 3D cancer models. So we call them tumor on chip, but there are other names that are used, for example, MPS, microphysiological systems, or NAMS, new approach methodologies. There are also the tumor organoids. So all these technology, they are part of an emerging strategy. And so here there is a difficulty to go from the lab to the clinic. As I explained before, we make co-culture in this chip, in this microfluidic device, and we use cells isolated from the patient to recapitulate the tumor ecosystem. We add also the bacteria to study the tumor microbiota. We treat this tumor on chip with drugs, and we are able to measure the response on chip. So our tumor on chip are by definition personalized, because we use cells from patients. but there is a big gap to fill. So we still have to rigorously prove with patient cohorts of appropriate size that the on-chip response correlate with the in vivo response of the patients. That we have to prove that the response we measure in our devices, they predict the response of the patients. This is the first major challenge. And there's a second one. So the diagnosis usually are done on fixed tissues. So the pathologist, they work with the fixed cells. We are working with living cells. So in this case, the hospital, the pathology departments, they are not ready yet. There is not the culture. There's not the know-how to make the kind of assays that we are doing with living cells. So the transition from the lab, so to make the tumor on chip companion diagnostics, is not for today, not for tomorrow, maybe for the day after tomorrow. But we are working as fast as possible toward this. And so we put a lot of effort to simplify, optimize, and standardize these protocols and these models in order to prepare the future translation to clinics.
I want to encourage the audience to ask questions. You can do so in Slido as well. So if you have questions, and they can be very scientific if you're a scientist as well. They can also be very layman type of questions, like my own, because we are trying to communicate this on all levels. And that goes for those of you that are with us online as well. Please don't hesitate to ask questions to our panel. If you want to address your question to a specific person in the panel, let me know. But I'm sure that somehow it will. The questions, the nature of the question will indicate where to address it to. But don't hesitate to ask questions. No, I actually encourage you to. We have a few more minutes to go before we round off. Let's keep talking a little bit about that integration that takes place from the lab and before we get to the patient, because there's also what we could call a cross-disciplinary integration. You've already touched on that. And maybe it's not only about being familiar with what goes on here and there, but also, just the fact that there are different groups, professions, there are different people speaking different languages, both in terms of their profession, but maybe even just their different languages as such. And they work under different incentive structures and so on and so forth. So that integration in itself can be difficult. Do you experience that as well? I mean, you have this network, but do you experience that those obstacles stand in the way of getting the very great research brought into the reality of the patients?
I think this is a very valuable point. I mean, we have, I'm coordinating also this IHI project, which is a private-public partnership, where you already have private and public partners coming together and stakeholders that are also involved in the decision-making about the reimbursement of new tests, which I think is very important. And I think we all have our own background. What is also very important in early diagnostics is the socioeconomic background. So we also have people in our consortium which have a socioeconomic background, so they do calculations. If you have the perfect blood test, to whom would you like to apply it? To the general public, to risk groups, to specific groups. And they also open, I think, up our minds. For example, you have a test that is 95% specific. You would say, oh, fantastic, 95% is fantastic. So you only have 5% false positive findings. But if you screen 100 million people in Europe and you have 5% false findings, 5% out of 100 million are a lot, right?
Right.
And then you create a lot of anxiety, a lot of costs, because people think they have cancer, but they don't have it, right? So I think these kind of considerations to add to all the, let's say, technology science questions that we have to deal with is super important, because sometimes it is very good to think really from the end. What could be the end product in order to really do the right research in the beginning?
Do you agree?
Yeah, absolutely. One effort that we have to do is to anticipate, to think the future.
Yeah.
Well, there are. This is what maybe experience can bring, or the fact of having worked in different countries, at least in my case, and interacting with very different collaborators, allows us to try to anticipate. But it's very difficult. It's very difficult to. I go back to our example. So we know very well our tumor on chip, our cells, but then we have to think in 5 years, in 10 years, if somebody else in the hospital will use the same strategies, the same. How can we prepare this? So it is. Look forward, anticipate things. Yes.
There's a question for you. Somebody's congratulating you on the intriguing work that you've been able to do culturing live bacteria from tumors, and a person is asking, what are the main species?
Okay. My background is not in microbiology, so to develop this project, this Arturo project, we had to reach for collaborators, so expert in microbiology, and so I'm telling what I learned for our collaborators.
So you yourself, of course, are an example of the cross-disciplinary integration.
Exactly. Yes. Yeah. This is essential. Yes. So it's not possible to know everything. I'm a cancer biologist. When I learned that there are bacteria in the tumors, I reached out for collaborators, and I found very good collaborators that worked a lot on the gut microbiota, and now is working on the tumor microbiota. So it's our collaborators that are able, thanks to very specific technology and methods to culture the bacteria. There are many different bacteria, and the difficulty in the field now is to go from bioinformatic analysis that might be correct but might contain some errors, to what is called culturomics, so to really grow the bacteria out of the tumor. And these bacteria are not very simple because they are often anaerobics, means that they do not like the oxygen. Yeah. And so in normal lab, we culture the cells in presence of oxygen. So there are different species. Really, I don't know if I can make a list. There are Lactobacillus, Streptococcus, very difficult name to pronounce, and about the common.
Can you say a little bit about where? Maybe I'm asking entirely the wrong question, but just following up, just to explain a little bit, where are these bacteria found elsewhere? Does that make sense? I mean, just to explain what kind of bacteria we're talking about, other than anaerobic.
Actually, this is again a new concept. There are in our organs. Well, let's mention the breast cancer. So in the breast there are bacteria, and when there is the breast cancer that appears, there are some bacteria are more present, and other are less present. Right. So the state of knowledge right now is that the bacteria were there already. And the disease changed the balance, in particular the immuno capacity cells. So there are some, the bacteria, it seems that they are found in the immunosuppressive niches. So where the immunocells are less effective, there are some bacteria that can proliferate and do what we have to discover.
And Dr. Pentel, Professor Pentel, sorry, there are a couple of questions that actually tap into something you said before about making the liquid biopsy like a routine in cancer care, or even part of screenings in Europe. So, and you were talking a little bit about that before. What are the constraints of the vision of making liquid biopsy for multiple tumors to screen, and what needs to happen for liquid biopsies to become routine in cancer care? And I'm putting these two questions in one because I think they're sort of related.
Yeah, I think there are some fantastic technologies that can really screen for multiple tumors from blood samples that are also now tested on hundreds, thousands of individuals in different European countries. I think challenge or constraint is really if you have a test that in principle can detect every kind of tumor, many tumors, okay? You usually don't know exactly which type of tumor it is. I mean, some of these tests can make it a bit easier by telling you it might be tumor A, B, C, or D, so you can also narrow it down. But I think it's very important for the subsequent clinical workup to tell the radiologist, for example, where to make a scan, right? Whether you have a brain tumor or prostate cancer. And so I think these tests are getting better and better, because to have this tumor of origin information is very important to really find your tumor and then also get rid of it. And I think this is also super important then to make it really become a kind of routine care, then to go to the healthcare professionals in each of our countries and convince them that these tests are really should be reimbursed. So reimbursement is certainly the process of getting things into routine care. And for that, you need the socioeconomic calculations to convince them that you save not only lives. Unfortunately, it's not enough to save life. You also have to make sure that we can pay for it, our societies.
Yes. Okay. There's somebody who wants to know how we can ensure safety of patients via, for example, vigorous validation and regulatory approval, and shorten the road from research to implementation. I think that will take us a little bit too far into something a little bit different.
Maybe just one word to that. We have to reduce bureaucracy. I mean, many people think that researchers don't want to collaborate. That's totally wrong. We love to collaborate. But in order to exchange a blood sample from University of Hamburg to University of Copenhagen, it may take 12 months of paperwork because we have so many regulations that have made our research life so difficult.
So you need corridors for researchers to exist.
There should be roads and
that be a message to the policymakers here.
Exactly.
Yeah, I will add on this because, for example, in the context of the Arturo project, we are very limited by the fact that we still cannot send samples from one country to the other country. And this is because there is, in this case, legal obstacles. So we need to sign what is called the consortium agreement, which is an extremely complex process, and really it is a limitation for us in this moment. So.
Okay, so let this be the message from the Cancer Mission in Copenhagen. Please provide corridors for scientists so that they can collaborate closer and faster and more agile. Because it seems
Thank you.
There's a data
we're working so hard on this.
There's a data protection regulation that is supposed to protect the patients. But
And
that
I'm sure it
leads-
does in a lot of senses,
that
but maybe the
leads to a
patient is dead
reduction of
before it's been
research,
just
which
protected.
is not in the interest of the patients, right?
Yeah. Okay, but we sent this message, and I hope policymakers are listening in here, because this is certainly a place that I think we can all agree that it would be a very good idea to change things. I want to thank you. I want to thank you for your excellent questions. And here towards the end, I want to add thank you for all the work that you do, first of all, and thank you for participating on this panel. I'm very grateful for that. Thank you.
Thank you.
And I think we deserve a cup of coffee now, don't we? And we will have one, and then we'll return with our poster viewing session in 30 minutes. So that will be 11 o'clock.
Introducing the all-new EU Funding and Me app. The app that transforms the way you search, manage and make the most of your EU-funded projects. Combining the thousands of opportunities on the Funding and Tenders portal with the ease of use of a mobile application. Save your searches, bookmark your favorites, and never miss a deadline, event, or news item thanks to personalized notifications. Boost your knowledge through funding-related news and info days with in-depth information and insights. Coordinating EU projects? No worries. The app makes it easier to reach out and stay connected. So, if you have an idea, Eureka, download EU Funding and Me.